In our efforts to deal with COVID-19 pandemic, the government has disbursed a conditional grant of 5 billion shillings to all 47 counties. This is aimed at bolstering the level of readiness in our health facilities, specifically for COVID-19. This money is a conditional grant divided amongst the counties in accordance with the formulas designed for them and with agreement from the Council of Governors. The reason is that it is now up to the county governments to utilize these funds to safeguard the lives of our people by ensuring that our local health facilities are well equipped and our healthcare workers are adequately catered for. If our counties are fully prepared and have the necessary infrastructure in place, then we shall have nothing to worry about. However, we all know what happens when the reverse takes place. I would like to reiterate here that this 5 billion is a substantial amount of money. Now, this is not to replace what the government, what the health ministry has already been doing for the counties. We have been supplying PPEs, we have been supplying ventilators, we have been giving additional support to the counties, and we will continue to do so. But we felt it is important for counties to take responsibility in terms of the preparedness, particularly issues to do with the isolation facilities, issues to do with quarantine facilities, issues to do with monitoring with health workers, community health workers, training them so that they are able to take care of COVID patients even in their own homes. So what we are saying is that this is to establish a deeper, the money is there to establish a deeper relationship, a deeper understanding, a deeper association with us as we continue to fight against this pandemic. With the fight against the virus continuing, we have realized that over 80% of our patients in hospitals are asymptomatic, and therefore, baby can and may be managed from home. If this is implemented, it would free our health facilities from congestion. Because we are reaching, for example, in Nairobi, at a time when Bagathi, both Bagathi and KU, are already getting to full status. The Ministry of Health is in the process of actualizing, and indeed, we have already completed the process of actualizing home and community-based care protocols for rollout and to be implemented countrywide. What this means is that a lot of people who are in isolation facilities may be released to be taken care of at their homes, provided two things happen. A, it is in accordance with new World Health Organization protocols that we are still looking at and trying to customize and domesticate to our situation. Number two, it has to do with the facilities that families may have, and where no such, and where families are not able to either self-quarantine or self-isolate, the government will still assist in the process. But I would like to make it clear that a time is coming when we cannot continue as usual, that we have to change tax. Taking care of 500 people is not the same as taking care of 5,000 people. And obviously 5,000 people is a completely different ballgame from 50,000 people. We have learned over the last 3 months or so, we have been in school learning how to manage this disease, understanding this disease, going with the protocols that we were learning from other people. But now the time has come when we must also begin to implement our own systems in our own place, depending on our own environment, and because it is the only way that we can be able to cope with what we are expecting in the future. So I am appealing to all Kenyans, as soon as this protocol is out, that when we see people coming home, we will understand two things. There are no danger to us, first and foremost. There will be no danger to us, and therefore, there is no need for stigmatization. It is not necessary. You will be safe, but the people concerned will have to take care, and the families, you have to take care of them, so that they do not, because they do not need hospitalization. On that same note, my attention has once again been drawn to cross-border truck drivers. In the last few weeks, we have witnessed a large number of truck drivers at border points testing positive. Let me make it clear that all drivers take a COVID-19 test at least 48 hours before embarking on their journey and acquire a COVID-19 free certificate. We have, however, noted that a majority of the truck drivers are commencing their journey to the borders without this valid document, expecting to be tested at the border points. This has resulted to unnecessary congestion and delays that have been witnessed at our border points. This is purely indiscipline, which is unacceptable and will not be tolerated. I'm urging our law enforcement officers to take appropriate action against each such driver flaunting these measures. Na wajua tunaambia mambo mengi tukiwa hapa, habari hawa madereva. Kule port KPA, wale ambao wanaingia huko wakiwa na magari, kwa sababu tumetoa amri ya kwamba hakuna driver ambaye anaweza patiwa mzigo na gari akiwa yeye hana COVID-19 certificate. Lakini wale wanafikiri ni wajeuri sana, wanapatiana gari zao, wanaingia port na driver moja ambaye ana certificate. Anaingia ndani ya port, anatoa mzigo, akitoa mzigo kufika hapo nje, anapatia driver mwingine ambaye hajafanywa test. Huyo sasa ndio anatoka kutoka hapo, anaenda mpaka Busia. Na mimi nashangaa sana kwa sababu najiuliza, kutoka Mombasa jameni, na mimi nikitembea mimi mwenyewe nasimamishwa roadblock mengi. Huyu mtu ni kusema amepitia njia ingine ambayo haina roadblock, ama ni kusema alipitaje roadblock na anaenda mpaka Busia. Mimi sitaki kusema ati kuna kitu ama mimi sioni, lakini wewe mwenyewe jiulize. Hata ukiwa wewe sio mwelevu sana, unafikiri alipita namna gani kutoka Mombasa mpaka akafika Busia? Alifikaje huko? Pertaining to our COVID-19 situation today, 124 people have tested positive from 2,640 samples in the last 24 hours. Therefore, the total number of positive cases in Kenya now stands at 2,340, while the total number of samples tested so far is 87,698. The positive cases include 119 Kenyans, 2 Somalis, 2 Tanzanians, and 1 Eritrean national. These figures do not include the number of foreigners we have tested at the border and turned them back to their countries. Mombasa had the highest figures today, standing at 40, while Nairobi at 38, and now Busia at 26. You can see what I'm talking about. All these 26 people you are seeing here from Busia are essentially truck drivers who are being tested at that spot. Now, which then bears and brings a big problem for the Busia government, because it means you have to start quarantining, isolating, people who are not necessarily from the Busia County. Kajiado, the same thing, with 6 of them again, and so on and so forth. Now, today, Elgeyo Marakwet becomes the latest county to report a COVID-19 case, bringing now the total number of counties that have been affected to 36 out of the 47. In Mombasa, the 40 cases that were there, out of the 40 cases, 14 of them are from Mvita. Again, the same thing. We have 14 from Kisauni and 11 from Changamwe. The same trend again in the same areas. In Nairobi, we have 38 cases from Kibera, 25 from Kamukunji, and 25, and the cases from Kibera, a lot of them are in the quarantine facilities. 25 from Kamukunji as well. I would also like to add that in terms of gender, again, 100 are male and 24 are female. We still have to come down and find out why over 70% of the infections are still in male and are still the male gender. In Garissa, the 2 cases that we got came from Dadaab, and while in Muranga, we have 1 case which is in Kiharu. Now, when you start hearing of these rural areas, then you know that we really do have community infections. We are also happy today that we have discharged 39 patients from various health facilities, bringing our total number of recoveries to 592. We want to pray that we get more of those, and we want to completely support and thank our healthcare workers for the work that they continue to do to see that as many of our people as possible recover. Unfortunately, we have also today lost 4 patients to the disease, bringing the number of fatalities to 78. Our sincere condolences go to the families.
We are also exploring the possibility of community-based isolation. And Waziri, allow me just to highlight something about home-based care that you are going to launch very soon, probably by the end of this week or early next week. And this is a key intervention that is approved by the World Health Organization. And it is meant to decongest health facilities and prevent the healthcare systems from being overwhelmed. Remember, majority of our cases are asymptomatic. So it makes no business sense to be able to manage these people in a hospital facility. You can be able to manage them in a home-based isolation facility or a community-based isolation facility based on that risk mapping. And this has worked very well before. You remember during the early days of HIV, the pandemic, low middle-income countries were able to quite well work out on the intervention of home-based care with very, very good success. And also because we are going to carry out behavior change communication to the community so that we have their buy-in, we believe that we should all succeed together in this. Remember also, as a clinician, patients recover best at home because they're more familiar with the home environment rather than a hospital-based facility.